availability of kits, because anti-10A monitoring also gives a direct correlation with antithrombin. They are not related, but APTT and anti-10A are related. So if today you do the investigations in hematology, because I research on this subject, you'll see a lot of anti-10A and correlation with these parameters come up. So those are the 5 tests that I wanted to tell you you should do on an ECMO patient. And the 6th most important is platelet count. Maintain your platelet count above 80,000 while your patients are on ECMO. If not, give platelet concentrates. So no need to give whole blood unless, as Dr. Oja was saying in the morning, your hemoglobin is less than 9. At AIMS, our trigger is 9. Less than 8, transfuse 2 units. See the hemoglobin, maintain the hematocrit above 35-40, and your patient's good to go. So initiation of ECMO brings about activation of the platelet cascade, the intrinsic extrinsic pathway. It brings in a dilutional coagulopathy, a contact factor pathway activation with thrombin generation. What is the root cause of all this? The excessive generation of thrombin. And what does thrombin do? Thrombin enhances the effect of heparin. So heparin as an anticoagulant with more thrombin is going to cause more bleeding. So that's why you are in an era where most of you were asking in the morning that should we have heparin-free days? Yes, you must. If ELSO says that the guidelines for heparin usage is something to the tune of 20 to 50 units per kg and maintain it 10 to 20 units per kg per hour, maintaining all the time your ACT between 160 to 220, then today there are papers coming up saying that maintaining a heparin dose of as low as 10 units per kg per hour is also good. Even a 120, 140 ACT is good. Those are the recent studies which have come up in 21-22 post-COVID, and most of them today are monitoring the antithrombin 3 levels. So what do you monitor in your patient? Besides these 6, you monitor your hemoglobin. You keep looking at the urine for red urine and you keep monitoring your plasma-free hemoglobin. The moment your color is a hematuria patient, it means there is some presence of plasma-free hemoglobin. Get it done at least once a week. Increase in bilirubin is what you see, also an increase in creatinine. The urine color turning red should be monitored, and creatinine with urea should be monitored. Urea does not go up in a ECMO patient unless the ECMO patient is dehydrated. So give adequate volume, give good ringer or good normal saline or DNS or a plasma light which is as beautifully balanced as the human body's pH, but prevent myocardial stunning. We don't know today, but it is going to be in the future of you people doing the research. But the moment you have a prolonged myocardial stunning, which happens in a VA ECMO very often, you'll have your patients bleeding more. VA ECMO bleeds more than VV ECMO. And why? Because a poor coronary filling due to prolonged ECMO causes a subendocardial ischemia. So pulmonary artery hypertension is another cause of bleeding. So rule out any left to right or right to left shunts, rule out pulmonary edema, any acidosis. Basic CES and pH are the best biomarkers. Easy to do. Do an ABG, which will give you a pH, a bicarb, a basic CES, and it will give you a lactate. Along with it, you'll also monitor the glucose. And when you do this, if your sodium and potassium are all right, there's no dyselectrolytemia, you know your patient's doing well. So first do an ABG, then the platelet count, then your ACT, then your APTT, PT-INR together. Then look out for advanced tests like antithrombin 3 levels and anti-10A levels. But rule out increase in bilirubin and creatinine. They go hand in hand. Also remember that most of the VA ECMO, especially the pediatric babies who are on prolonged ECMO, suffer from 3 complications. One is infection and sepsis. Fungal sepsis on the rise everywhere. Because of overcrowding, even in the ICU, we don't give adequate space. I personally feel there should be an ECMO and a VAD ICU. But I'm sure with the population that we are in and the hospital staffs that we have, it's difficult. But I just saw it yesterday at Narayan Vidyalaya. 5 patients on pediatric ECMO, each one of them in isolated room. And this, if Dr. Devi Shetty can think ahead of times, all administrators should think ahead of times that you need this kind of a scenario where isolation of the COVID patients, especially on ECMO, is a must. So you'll have less sepsis. You maintain your systemic heparinization. What we did in ECMO in 8 of our cases, we did not give them heparin because they were on enoxaparin or Clexane BD doses. And we were able to find a lab which did our anti-10A and APTT together, with ACT and ABG being done from our ECMO labs. So when we did this, we saw our patients as heparin-free periods for up to 5 to 6 days. And on the 6-7 days, just before decannulated, we started a low dose of heparin. Many people and many centers in COVID did a lot of trial and error, and they did well. But always remember cannulating a patient, doing good monitoring with SCVO2. This is the SCVO2 scenario where we had a ECMO patient in ARDS shock, and this patient was on 6.5 liters with FiO2 was increased from 0.8 to 1 because all the time PO2 was less. And when the ECMO cannulas were put in and labs were done, our patient did very well. So these were some of the simulator signs that we saw, and we saw the delta pressure rise. Both the P2, P3 pressures, which Dr. Ojha just showed you very beautifully, rose, and we knew it was the oxygenator which had failed on day 1 itself. We were using at that time a cone and an oxygenator which was by the Sorin group. We changed the oxygenator. Our ACT was 171, all maintained. And when we had the MECA in oxygenator in the quadrox, we saw and looked for any clots, any oxygenator change, or any circuit leak, and we found none. So it's important to do your pre-membrane, post-membrane pressures, rule out first all the clots in the circuitry and also in the oxygenators. These are very, very important if you're doing it. Also, keep monitoring the revolutions per minute of the centrifugal pump. They're important. The Medtronic pumps that we use at AIMS, we use very little of the MECA pumps, but we use the Medtronic pumps and the SANS pump. And when we use these are bigger pumps, as was told to you in the morning, with higher flow rates. And the moment your flow rates are high, your hemolysis is more. So look out for thrombosis as well as more hemolysis when you have, and also look out at on day 7 and above, particularly in children, for intracranial hemorrhages. Communicate and call for help. This is chattering that you see on your circuit. Chattering when you see of excessive movement of the tubes, whether the venous and particularly the arterial cannula tubes, then you must verbalize to change the oxygenator and the circuit, because chattering is showing drainage insufficiency. And drainage insufficiency means there is a clot right at the outflow cannula. The return cannula is to be protected. So your access or the drainage cannula, which is the bigger size cannula, has some clots, and these clots will cause this excessive chattering. So avoid the chattering, and once you see it with a torch, see it and look out for small clots or emboli anywhere all throughout. And you'll see once it happens, there is a clot sitting at the drainage port. We saw it in this patient and we changed it. So saturation and monitoring for anticoagulation go hand in hand. Hemodynamic monitoring and anticoagulation monitoring. So maintain your mixed venous oxygen return. If you have a PA catheter or a SCVO2 catheter or just a plain SpO2 above 70%, and if it is less than 88%, then see the kinking of the lines, rule out any fluctuating of the flows, rule out any high inflow pressures, that is your P1 pressures, is it becoming more negative? Rule out hypovolemia, very, very important. See that the cannulae have not migrated. Any malpositioning of the cannula, it's very easy to see. You see the cannula site where it's inserted in the patient's skin. If you see any oozing there, you see any cast there, you see any whitening and a thin film forming there, it means clots are going to happen. It means your coagulation system is activated and excessive thrombin is forming. So that's the moment you need to have all your detailed tests done. But if your patient is having fever, is in sepsis, or has had hemorrhage somewhere in the subperitoneal cavity or the intracranial hemorrhage, and the demand has gone up, in that place you increase your flows, see your PEEP on the ventilator, increase your hemoglobin. Now is the time to give blood, and at all times decrease your carbon dioxide. This is where we need things like Novalung, a low flow ECMO. You don't need high flows, though you've increased the high flows, but your PCO2 in some scenarios remains high. If your PCO2 is remaining high and your PO2 is low, it means slow down on your flows. Do a low flow ECMO. And what gives you a low flow ECMO is end-tidal carbon dioxide removal, bio-nova lung kind of a machine. Most of these machines that you saw in the morning also can be run very beautifully on low flows, but you must have expert perfusionists to perform the low flow ECMOs, and you must know everything from the manufacturer of what to maintain on the PO2s and PCO2s. But if your myocardial oxygen demand is more and it's more than 60%, you must also rule out recirculation. So anticoagulation problems also involve ventilatory changes, your flow problems, and your recirculation and your monitoring problems. So that is what the inside of a Mackay Cordrix oxygenator is. It's full of polypropylene, and when you have methyl polypropylene oxygenators, even that oxygenator, that video was for that, needs something which has a shorter turnaround time, something like the Rotom. So this is the Rotom machine, and I wish I had the machine with you, but if all of you are there at AIMS around the 1st of November and the 4th of November, I invite you all for a direct anticoagulation workshop, which you can see live from your homes. You have 4 channels. These 4 channels, the extem, the intem, the extem and the fiptem go together, and the intem and the heptem go together. Are channels which have neutralizing factors inside them in those small cuvettes, whether it is ellagic acid for extem and fiptem, or it's something like calcium chloride for heptem and intem. You have a tissue factor to which you add patient's arterial blood, 0.4 ml, in that cuvette. You run it in an electromagnetic field with a cup and the viscous coming and moving this cup which houses your patient's blood with the tissue factor in between, and you get this kind of a signature. The moment you get a signature like this, which is a Rotom signature, the first one is an extem. So that has an art time, it's a different science and a different art, but these signatures, whether of sonoclot, whether of TEG, whether of Rotom, TEG and Rotom are quite alike. They go hand in hand. There is just a modification of the speed with which the cup and the pin move in that electromagnetic wavelength of the machine. And the contact factors that they have used, whether it is tissue factor, ellagic acid, or calcium chloride, or silica beads as they use in case of sonoclot, they give you different factors. Now you can see the extem and the fiptem on the left and the right side. The bigger one is the extem, that takes care of the extrinsic pathway, and the fiptem takes care of the fibrinogen pathway, which comes in as a part of the common pathway. The ones below, the third and the fourth, are the intem and the heptem on the right side. This has neutralized the heparin factor. So it has heparinase beads in it, and the intem has calcium chloride. So once the intrinsic pathway factors are neutralized, you come to know how the patient's blood is maintaining those factors. So these tell you, like if you have a decrease in the fiptem, it tells you that your fibrinogen is less. If it is beyond that line that the manufacturers has set, you can see the dash lines, it means there is a hyperfibrinogenemia. It means your fibrinogen levels have increased, right? So this way you come to know within 15 minutes of the test coming in. You can see it's moving at this speed only. In 15 minutes, you come to know what is your factor component deficiency. In 10 minutes, you come to know the R factor. The R factor, the amplitude, the MCF, the lysis. You have the last part, which is the lysis. When the platelets which have aggregated lies down and the clot resolves. So within 30 minutes to 60 minutes, your clot should resolve. If it does not, and there is a thrombus there, it means your patient on ECMO is forming a thrombus and it's undergoing thrombosis. What do you need to give? Do you need to give blood here? No. What do you need to give for thrombosis? Anyone? You need to see what is the cause of the thrombosis. So the first cause would be to neutralize it, the heparin. So give some protamine. On an ECMO, you would not want to give protamine, right? Normally in a cardiac patient, you would give protamine. But here you don't want to give protamine, so stop the heparin, right? Now you've stopped the heparin and yet the thrombosis is happening. It means some factor deficiency is there. So first see the patient's temperature. Is he or she hypothermic? Next, give an antifibrinolytic pathway activator like we used to use aprotinin once upon a time. Today we use ECA, which is an epsilon aminocaproic acid, or we use tranexamic acid. Once you've given that, if you can see, this was a normal extem, intem, fibtem, and heptem. You saw the four clots. So if they are not normal, if they are increased or they are decreased, we come to know what the factor is. If it is not so, and you first rule out your diuretics, your PEEP, there's no pulmonary edema, you see the FiO2 on ventilation. If it was 100, you go down to 0.6. If it improves or not, you may use another mechanical assist device with ECMO like IABP or a VAD, and you decrease the ECMO flows and consider weaning. But if it still bleeds and the thrombus is still there after the antifibrinolytics are given, what do you do now? Give FFP, don't give blood. Check the hemoglobin. If the hematocrit is more than 35, if your platelet count is all right, no need to give platelet concentrates also. Just give the tranexamic acid and give to your patient after that FFP, 2 to 3 units of FFP. Your patient will 80% be satisfied. If not, now is the time to think of cryo. So in a very stepwise manner, maintain the hemoglobin with blood, whole blood, maintain your fibrinogen with cryo, maintain your platelet count decreasing with platelet concentrate, and maintain overall heparin effect and residual heparin effect less or more with FFP. So that is the rule of the thumb that we follow. How much can you give? Well, I'll give you scenarios where you can go up to 15 units of cryo and nothing will happen to the patient. So remember, heparin is responsible for platelet aggregation. Heparin is a prodrug. Heparin with the platelets brings about anti-aggregation also. Heparin is monitored by ACT, APTT, anti-10A, and a point of care like sonoclot, rotum, or TEG. In ECMO patients, prompt attainment of therapeutic anticoagulation with heparin is important, and APTT target should be on the lesser side between 40 to 60 seconds and also maybe 60 to 80 seconds, but less than 78 and less than 50 is to be targeted for thrombosis. You do a point of care, whether it's a rotum or a TEG or a sonoclot, one must be an expert at it. That's Dr. Robert Bartlett at the 2018 conference in New Delhi. And I want all of you, I'm standing here as a SWAC ELSO president. Dr. Pubani, Dr. Venkat, Dr. Mehta have been the past presidents of SWAC ELSO. Please do come to Ludhiana and enjoy a feast of SWAC ELSO 2023, which Dr. Vivek Gupta is organizing. You'll understand how important ECMO has become in every ICU today. So that's the sonoclot machine. It's more or less like the Hemocron or the Medtronic ACT machine that you use. It has 1 or 2 channels. The 2 channels houses a cuvette, small cuvette. You can see the space. That's the electromagnetic field that it works on, and it is attached to a laptop. It controls all blood product usage. Why do we need these point of care testing? Because these point of care testing tell us what blood product to be used when. So in this era of restrictive transfusion, where triggers of transfusion are important, it's important if your hematocrit is good, don't order blood on ECMO. Order the right blood component therapy. It differentiates between mechanical versus hemostatic disorders. Very often on ECMO we feel a surgical site may have become loose. It's a mechanical bleeding, iatrogenic bleeding, whereas sometimes a thrombus anywhere in the circuit or a migrating cannula may bring about a bleeding. So you must know what the patients are, and very often because we are using heparin resistance and heparin-induced thrombocytopenia type 1 as well as type 2 are very often seen. So this is a sonoclot graph. You see in a sonoclot graph here, if I can explain the graph to you, if this is moving, I think it's coming on of its own. You can manage with this, the sonoclot therapy. When you see this, you see the clot formation as the clot rate, which is the rise. You see the clot peaking. That's when the platelets and the fibrin have aggregated to give you a solid clot. And then the decline phase where the clot is lysing. How much time has it taken? Up to 40-45 minutes. And this sonoclot, this rotum, this TEG gives you in 40-45 minutes a DR15 value. What is the rate of decline? DR15 in 15 minutes. It gives you a PF-SON value. What is the platelet function at the end of 15 minutes? If it is more than or less than 0.9, I know what to give. If it is less than 0.9, I'll give platelet concentrates. If it's more, I'll not give any platelet. I won't order any platelet. So that's how these work. We see the peak, we see the decline, we see the rise. And with heparin, there will be no decline. So this is the clot formation rate. 3 steps: time to clot formation, rate of fibrin gel with the platelets, and the clot retraction of the fibrin gel, and therefore the role of fibrin all throughout. So onset time or activated clotting time is what you see, the liquid or the gel phase, and then you see the peaking, and then you see the decline. Fibrinogen converts into the fibrin gel during this platelet aggregation in 15 minutes, and you form a clot rate as a steep sharp rise. So I hope all this is very clear. So your peaking is your clot formation, the tightening. The clot retraction is your decline, and pulling away from the surface is your total decline or the lysis. So time to peak is what we notice, and all this comes on with the normal on the bar beneath and your values on the side. And it tells you what to give. So post-protamine and an anticoagulant patient on heparin, there'll be just a straight line or very small bull's hump. In a baseline of a normal patient, there will be a normal peak with a normal decline. In a post-protamine patient, the peak would be slightly less. It will take time for it to form and come back in 2 hours' time. So typical cardiac surgical patients will be this. In platelet dysfunction, if this was the baseline, you've given platelets, you've given protamine, this was the baseline. Now you give post-protamine after heparin, that would be the baseline. So our object is to monitor heparin to prevent clot formation, but also excessive clot with too much of heparin or too less of heparin is also wrong. So this is a post-Fontan patient whom we put on ECMO. This is a total correction on ECMO, and we got these platelet dysfunction curves. When you get this kind of a curve with a double hump and a peak, it means your patient has normal hemostasis. But can you see those values below? A 3-year-old child undergoing a total correction. 164 is your clot rate, which is normal. ACT is 164, sorry. The clot rate is between 9 to 30, and here it's 12.8. And your platelet function has to be more than 1.6. Here it is 2.3, so it is more, and everything is normal. But the moment you come off and you give protamine, you see there's a deficiency. There's no peak and the decline is so less. The platelet function is 11 more than 1.6, it's 1.3. But what has happened is your clot rate is less. So when your clot rate is less or it's borderline, this is a patient where you'll give some platelets and some FFP. Now this is a patient which is having a wide area of curve under its signature. When you have something like this is a hypercoagulable state. In such a patient, you will give first volume. And after you've given volume, you will give just no blood, no platelets, just wait and watch. This patient will become all right. So normal hemostasis on total correction, we put this patient on ECMO, platelet dysfunction on ECMO, and in 24 hours normal again, because to this patient we saw that there was a hypercoagulable normal stasis coming only because our platelet function was very, very good, 1.7. We'd given 2 units of platelets. So coagulation in ECMO therapy needs a complete correction. You have the extem, intim, and fibtim on the rotum. And if the CT, CTT, and the A time, you have the area under the curve at 5 minutes, at 10 minutes. And you have something very beautiful on rotum, and that is the platelet function test, which only the multiplate analyzer gives you, and which the Verify Now, which Rotum has sophisticatedly gives you. The new rapid TEG gives you a platelet reactivity. This is a monitor of how much of your platelet is active after the drugs of anesthesia, the drugs of sedation, and the drugs of cardiac patient like ecosprin or clopid your patient has taken. So if your platelet reactivity is less than 1.6 on a Verify Now, you know your patient needs only platelets. So give to this patient an Octa Pharma platelet concentrate, which is a manufactured thing, or from the blood bank, random platelets, and you see your patients do well. So platelets are the nucleus. Keep having a lot of intem, extem, and fiptem values of your patient at least 3 times in a week. Once you see they are normal and you compare it with the normal nomogram on the chart of the rotor machine, then you know if your MCF, your A10 is normal and your lysis at 30 minutes and your lysis percentage is between 0 to 18, you know your patient is doing well. So that's the way we use the TREG protocol also, which allows the administration of very low heparin levels. You can do no heparin or low heparin because you have a rotum in a blood bank or in your lab somewhere, or a TEG or a sonoclot. It is these point of care tests which have helped us. And of course, never not do ACT, APTT, and an anti-10A at least once on ECMO. So number of channels of a rotum are 4, and I won't go into the details, that's another test. But rotum parameters of aptim when we use the arachidonic acid, or of ecatem when we use the bivaldridine. Bivaldridine is monitored only through this contact factor, that is ecatem, which overcomes. Let me ask you, how does bivaldridine tested? By the Icarin time, ECT, right? Not ACT. So bivaldridine, if it is tested by the Icarin time, the ECT time, there is only one thing. If you are on a bivaldridine ECMO, we use a lot of bivaldridine, and we found a test dose of 1.5 for bypass normal and a test dose of 0.5 milligram per kg per body weight as a bolus for beginning ECMO common. We'll soon be writing our paper. We've done it on 10 ECMO patients, and we found wonderful results because we didn't have any monitor to monitor bivaldridine, and we got bivaldridine through the DGSI after permission for a research project. But once we did it on our bypass patients, 150 of them, we've also been confident to do it on 10 patients of ECMO. We lost 3 patients, not because of bivaldridine, but we lost them because of sepsis. But the 7 patients who did survive had this ecatem provided to us by the Werfen manufacturer. And ecatem is nothing but Icarin, which monitors the bivaldridine levels with calcium chloride. So these are reagents that you get in small reagent bottles, which you put with a multi-channel electronic pipette into the cuvette and add the patient's blood into it. I wish I could demonstrate it to you, and then you have these curves running for half an hour. And you keep going and seeing the curve there and the ECMO there and see the clots. Anticoagulation is just perfect with something like a sonoclot or a TEG or a rotum by your bedside. So if you buy a ECMO machine, please buy a echo machine and a point of care testing machine. The day I bought my own rotum about 2 years back, I feel very happy if I can use it. It's for more of research, but it's a very good tool. Fibrinogen deficiency is something that we see very common on ECMO patients. You'll see the pink become less than 7 millimeters. It becomes 3 millimeters, 4 millimeters. Give 4 to 5 units of trio to this patient. Repeat the fiptem with the extem, and you'll see everything's fine. So here the extem, intem, and heptem were fine, but fiptem is low. So when you do something like this, you know your patient's good. My last scenario would be something known as hyperfibrinolysis. How do you watch for hyperfibrinolysis? That means your patient has so much of deficiency of so many factors, factor 13, factor 12, the Hagman factor, 1 Willebrand factor, factor 8. These are some factors which, because of prolonged use of ECMO, as I showed in the first slide, have a consumptive coagulopathy. When you have something like this, then you know your patient is going to suffer the deficiency. The MCF on rotum, the amplitude would be less, and less than 30 minutes, it will start lysis and show a tapering. So your MCF was less, the lysis is taking in an advanced stage, early stage, your lysis 30 is less than normal. This is a patient who requires all 3. Give FFP 2 units, give PC 2 units, give cryo 2 units, do the repeat test after 4 to 5 hours, and see a hematocrit, and you'll see your patient do very well. So this hyperfibrinolysis curve also comes on onto the rapid TEG and the classic TEG machines, but it is the fibrinogen deficiency. One of our Fontaine patients, we do integrated ECMO at AIMS, where we put the patient with cannulas for ECMO. Then the surgeon completes the surgery, and instead of coming off on bypass, we come off on the ECMO machine. So all our L-kappas, all our Fontaines with obstructed TAPVCs, with D-switch, arterial switch operations, for DTGA, we do integrated ECMO. So when we're coming off on these small babies on ECMO, we don't waste time. It's cost effective. You're not using a CPB machine as well as an ECMO machine, right? Your cannulas are not doubled. So sepsis is maintained. Everything is in the hands of the surgeons. He remains happy that there's no sepsis created by the anesthetist or the perfusionist. But whatever is your call, it is cost effective. So when we do integrated ECMO, we know we continued the ECMO, we had this kind of a picture. And this meant because of the prolonged surgical time, the clamp time and the CPB time, our patient went into a prolonged ECMO also and a prolonged bypass also. So all these factors diminish. So you may have to give more of the blood components rather than whole blood. So you can do a goal-directed therapy on ECMO. You can calculate it by using a global end-diastolic volume and a cardiac index. We do it with the FlowTrack machine and the EV1000 machine. But it is with research on anticoagulation and innumerable papers, and that we have judiciously used ROTEM in our patients, predicted coagulopathy on ECMO, and we can say that platelet aggregometry can come up as a valuable tool to assess the platelet dysfunction on ECMO. HIT on ECMO is also very beautifully told on the point of care test. You will see that the heparin effect becomes a straight line. The heparin effect is not there. You may see a peaking on the sonoclot, or it may remain to be a no area under the curve. When you see something like this, then implementation begins on the ground. Train your nurses. Your crash carts should show the flows, your RPMs. You should be able to show that my trolley should have this much of blood, 2 units of blood, 2 of PC, 2 of cryo, 2 of FFP, against the name of this patient kept in the fridge. So train the nurses, because it's in the night that all the accidents happen. And if you train the nurses well, believe me, they are the best doers in an ICU. They'll never harm your patient. There may be a iatrogenic problem, but learn through algorithms. So at first, we were never taking care of the blood temperature, the hematocrit, and the antifibrinolytic. We were giving it last. This was 3 years back in 2016-17 when we came out with these publications. And then I met Dr. Klaus from Germany. He said, you're doing it wrong. You first stabilize your patient's temperature, the pH, the basic says. These are simple to do. If I have a bear hugger or a warmer under my ECMO patient, my patient will not bleed. My patient bleeds because of hypothermia, and this hypothermic drift happens on ECMO. It happens very often on prolonged ECMO. So when you are having something like this, give antifibrinolytics as your first choice, and after that you give any other test. Do a heparin protamine management. Sometimes you may need to neutralize that heparin and then restart your heparin in a fresh dose on a prolonged ECMO. We had a patient 108 days on ECMO. We gave the patient very obese, ARDS, and we gave the patient 4 days free heparin period, and then we gave protamine to this patient. Saw the ACT, saw the ROTEM, everything was normal to our surprise, and then we started a very low dose, 5 mics per kg per body weight per hour heparin, and our patient did well, 118 days. And then suddenly on discharge, the patient died in the house after 4 days due to an intraoperative ischemia. Now, whatever the cause, these patients teach you how to manage heparin protamine neutralization very well. So this myth that you don't give proton heparin is also going to go away very soon. But maintain protocols. Every institution should have the Panjan's Specialitica at Calcutta doing wonderful ECMO in COVID times particularly, and even now. I'm sure they have their own protocol of what to give when for anticoagulation. So whatever is your thing, maintain and prevent bleeding as well as thrombosis on ECMO. This is our latest study which has just been published in 2022. We use platelet function tests. We saw the area under the curve. We saw the ARATEM, ADP-TEM, and TRAP-TEM. What are these? These are reagents to obtain the aspirin, and we did this on CABG patients. So 100 CABG patients, 6 of them went on ECMO, and of these 6, when we did arachidonic acid to neutralize the effect of aspirin, add ADP-TEM to neutralize the adenosine phosphate pathway for clopid, and TRAP-TEM for any group 2B3 and dual antiplatelet drugs with also thrombin reactions obtunded, we saw that our patients did very well if we gave cryo first, because most of our patients were hypofibrinogenemic, then platelets, and last FFP. So our usage of FFP was only for heparin resistance or when we had hit in one of our patients. So platelet function test in CABG patients on ECMO, the 6 that went on ECMO all did well, predicts postoperative bleeding, and tells us before time with the area under the curve whether my patient is going to benefit with heparin continuing or not in the post-op. Most CABG patients do not require heparin if they are put on ECMO in the post-bypass period. So we are on to the patient blood management in cardiac surgical guidelines, and we also do ECMO guidelines with it. And for that only, I'm inviting you all for the 4th November at AIMS. This was a patient who was on VA ECMO with a switch and cardiac tamponade with decreased cardiac output, and drainage was more than 3 liters, and we did a PFT and we found FIPTIM to be less than 2. You can see small FIPTIM, and XTIM also to be less. And when we gave platelets, to our surprise, this patient did well with good area under the curve. So hypofibrinogenemia is the culprit in most patients of the studies that we've done in our 150 ECMO patients so far, neonates, infants as well as adults. Giving cryo has maintained a lot of help. And if we see this kind of a picture with decreased area under the curve and increased slope with a FIPTIM as a flat line and hyperfibrinolysis, then this is a patient in low cardiac output with a shock which is more or less hemorrhagic and not obstructive, not distributive. This is a patient which will require blood and will require FFP with cryo. So ROTEM, maintaining XTIM A5 less than 35 and FIPTIM CT more than 600 seconds is what we found to give us hyperfibrinolysis. We see this very less, but once seen, it should be managed only with tranexamic acid in a very large dose. Normal dose of tranexamic acid is 10 milligram per kg per body weight, but we can make it to 25 milligram also. I can go on and on with my cases, but I like to rest here. The difference in neonatal and adult anticoagulation and transfusion requirements demands tremendous clinical knowledge to provide the best care. Use of thromboelastogram, ROTEM, and sonoclot complement other methods currently being used for improved care on ECMO. And ECMO requires a multidisciplinary tree. I would request all of you train your, not just the perfusionists, but your nurses to maintain the patient well. Heparin with antithrombin 3 is the cornerstone of anticoagulation during ECMO. At least twice in a week, do an antithrombin 3 level. At least once in a week, do an anti-10A level. And if you can't do these, then point-of-care tests are the best mode. When you buy an ECMO machine, buy a point-of-care test. I'm thankful to my director, Dr. Guleria, who will be completing his term of 6 years, who gave me all support for all this research through our journal, the Journal of Cardiac Critical Care. We don't work for money, but we work together. Our national president, Dr. Yatin Mehta, my dean, Dr. Balram Aaron, the cardiothoracic surgeon, Dr. Robert Bartlett and his ELSO team, and my juniors like Dr. Jatin Arula and others at AIMS, who gave us all the impetus to come out with the second edition. We are coming out with the third edition of the ECMO book. It's not marketed much because of certain reasons, but the third edition is thanks to Dr. Guleria being marketed very soon. We do ECMO fellowships. We're starting a fresh batch. We already have 30 enrolled. These are online fellowships, which TSS does under the journal. And these fellowships, Dipanjan's been a part of it. He was the first batch. I remember him well. And he gave me very good results of telling me where we are to improve. And a lot of fellows who've gone back are today big in ECMO intensivists in 5 years. We have trained 1280 ECMO fellows across different parts of the globe. And I feel happy because they're online. In COVID times, many came on. But cardiac critical care remains our forte. And the Simulation Society at .net is where we are. And ECHO, as well as cardiodiabetes, cardiac nutrition, and patient blood management is what we all do. I thank Dr. Venkat and my entire team of SWAC ELSO for making SWAC ELSO happen. Thanks to Dr. Puvani's vision. In 2015, we are where we are today, but it's 25 centers from India, and that makes us stand tall. But it's people like you who are future leaders. If you believe in doing an ECMO course today in this prestigious institution with these kind of teachers, one day you should take the mantle on and do advanced ECMO somewhere else. Thank you all. Okay. Any questions? I can take a couple of questions. Any questions?